The following podcast is part of a certified educational activity titled Shielding Generations with Pneumococcal Vaccination Approaches Across the Lifespan. Access the entire activity and complete the post-test at peerview.com/JNR860. Downloadable slides and practice aids are also available.
Welcome to today's session, Shielding Generations, about pneumococcal vaccination approaches across life. I'm Professor Elizabeth Botelho-Nevers, joined by Professor Federico Martinón-Torres, and we will explore the burden of pneumococcal disease, evolving vaccination guidelines in Europe, and strategy to optimize vaccine uptake and patients' outcome in this session. Our goals for today is to augment your knowledge of who is vulnerable to pneumococcal disease and indicated for vaccination, to equip you with strategies for patient counseling to facilitate pneumococcal vaccination, and to provide guidance on pneumococcal vaccine strategies. And now the floor is to Federico to continue this session.
Thank you, Elizabeth, and hello, everybody. I think the first part of what we need to discuss is to, in some manner, give the correct size to the burden of pneumococcal disease and which are the specific risk factors that this disease may have. And what I can start saying is that pneumococcal disease is a life-threatening bacterial infection that generates a huge burden everywhere, every time. Here we are specifically seeing the burden in Europe. And as you can see, according to the density map, this is an important disease everywhere. In 2022, we are talking about almost 18,000 invasive pneumococcal disease cases. And it's important to bear in mind that this number of cases is only reflecting the invasive pneumococcal disease, and also that most of European countries are already immunizing their infants with some of the available pneumococcal conjugate vaccines, plus some of these countries are also immunizing the adult population with pneumococcal conjugate vaccines. So this is a huge burden, despite pneumococcal conjugate vaccines are still being used. So imagine the size of the problem without vaccination. This disease affects any gender. Maybe it's a little more higher, the incidence in males than females, but it can affect any age. But obviously, the highest burden is in the streams of life, mainly in the infants up to 5 years of age. But again, from 50 years onward, the incidence will increase again. Behind pneumococcal disease, we have 108 serotypes. However, most of the life-threatening cases, most of the more severe forms of disease are only caused by a reduced number of those serotypes. As a matter of fact, if we still keep in mind the number of IPD cases, the 18,000 IPD cases that were registered in the previous slide, and we try to address which are the serotypes behind them, only 11 serotypes will explain almost 3 out of each 4 IPD cases in 2022 in the European region, with serotype 3, 8, and 19A being the top 3 of these serotypes. Well, the importance of this disease is not only the amount of cases it generates, but also the high case fatality ratio that IPD, invasive pneumococcal disease, can actually have. We are talking that 1 out of 10 will die after suffering an invasive pneumococcal disease, particularly those that have a phenotype showing septicemia, but it's variable depending on the specific phenotype that the pneumococcal disease is generating in the individual patient. And as I mentioned, this case fatality is particularly high in the streams of life, in the younger infants, but also again from 60, 65 years onward, the case fatality ratio of invasive pneumococcal disease will further increase, with 6 serotypes explaining most of the cases, despite more than 100 serotypes actually can cause the disease. And of course, age is the most important independent risk factor of invasive pneumococcal disease, the streams of life. But there are also specific conditions that increase the risk of pneumococcal disease irrespective of age. And these are specifically any immune depressed condition that will increase the risk of IPD irrespective of age, but also the comorbidities that usually increase with age, namely chronic lung disease, kidney disease, chronic heart disease, and other comorbidities that increase with age and together with the risk linked to age will further increase the risk of invasive pneumococcal disease in the population. So now we have discussed a little bit about the burden of disease, and I'd like to ask you, Elizabeth, more specifically about the older adults and what happens beyond the acute phase and how pneumonia, which is the most frequent phenotype in the older adult population of pneumococcal disease, has additional effects and risks for the patient.
Yes, indeed, Federico. Notably in older adults, beyond the effect and the lasting effects of pneumonia, for instance, we now know that pneumococcal infections will increase the risk of cardiovascular events, for instance, in the days after the beginning of pneumonia. It seems to be really associated with Streptococcus pneumoniae more than other agents of pneumonia. It is also associated with functional decline and, as you underscore, with mortality. So this clearly emphasizes the value of the prevention of this disease beyond the prevention of infection. And Federico, I'm thinking about what about the burden that extends beyond invasive pneumococcal disease. We talk about that, but indeed, I think it's important maybe to emphasize this again.
Yeah, thanks, Elizabeth. I think that, well, it's clear that our main target is try to avoid and acknowledge the importance of invasive pneumococcal disease, but this is only the tip of the iceberg. Actually, pneumococcal disease can also generate additional phenotypes, maybe less severe, but much more frequent, meaning a huge amount of burden, not only for the patient, but for the healthcare system and for everyone around, because we are talking about pneumonia, not only bacteremic pneumonia, but pneumonia in the community. We are talking about sinusitis. We are talking about otitis. We are talking about different phenotypes that explain an important amount of disease that sometimes is, let's say, under-recognized because we do not do a specific etiology in these clinical phenotypes. Most of the times in primary care, but even in the hospital setting, we are not able to finally end with the specific etiology of a patient with otitis or pneumonia. And we know that most of the times pneumococcal will be the cause, pneumococci will be behind those clinical cases. But in our daily practice, we do not specifically identify pneumococci in these patients. But this does not mean that pneumococci are the one, if not the main cause in many settings of these, let's say, mucosal forms of disease of Streptococcus pneumoniae. And I think this is important and links to other potential roles of the pneumococcal vaccines as the role that they may have over carriers and the additional benefits. So, Elizabeth, you may further elaborate a little bit in this regard about the carriers and the importance of carriers in with pneumococcal disease.
Yes, indeed. Asymptomatic carriage of Streptococcus pneumoniae clearly drives the transmissions, notably between children and adults, and also the resistance. And it's very important to notice that conjugate pneumococcal vaccines, and it was not the case with previous non-conjugate vaccines, have an impact and reduce clearly the carriage of pneumococcus. So through vaccinations, we can have an impact on transmissions, and it will be associated with herd immunity. And the impact of pneumococcal vaccines will be also seen on the reduction of antimicrobial resistance. And I think it's also an important benefit associated with pneumococcal vaccinations.
Okay, thank you, Elizabeth. Maybe from here we can move into this next section and you can further elaborate on the actual tools we have, the pneumococcal conjugate vaccines that we have to fight against all this burden that pneumococci can cause.
Indeed, even without the vaccination of adults, we can observe, thanks to the vaccinations of children with PCV7 and PCV13, a reduction of case of invasive pneumococcal disease in adults and notably in elderly. However, it was a very nice story for maybe more than 10 years. But lastly, we can observe since 2020, indeed, a new increase in cases of invasive pneumococcal disease in children and also in adults. And we can observe serotype replacement. And this serotype replacement was indeed associated with the need to develop new vaccines. If we look at the impact and the public health impacts of pneumococcal vaccinations and conjugate pneumococcal vaccinations, we can indeed observe herd protection and herd immunity and an indirect effect of the vaccination of children on the prevention of infections in adults. We indeed observe this serotype replacement that clearly poses a challenge that needs the development of new vaccines with a broader serotype coverage. We also observe since the beginning of the recommendation of pneumococcal vaccination in adults, very important coverage gaps, because indeed in older and in at-risk adult population, the rates of pneumococcal vaccinations are very low and in all the countries of Europe. And it's important indeed to improve pneumococcal coverage vaccinations, to also have cost saving, because at least in some countries, the pneumococcal vaccination was associated with a very positive return on investment for vaccination, especially in high-risk group target populations. So with a serotype replacement, we have a development of PCV20 that is based on the development of PCV7 and PCV13. And there is supplemental pneumococcal serotype that have been added to this platform. And there is also recently the development and the approval of PCV21 that have some serotypes that are common to PCV20, but there is also other pneumococcal serotypes that have been added in the vaccine PCV21. For PCV20, the developments have been done using immunobridging data, and indeed for PCV20, but also for PCV21, real world effectiveness data are now weighted, because indeed we have immunological data showing non-inferiority. Regarding PCV21, there is data and approval in adults. And when we look at the vaccine coverage and the serotypes associated with notably invasive pneumococcal disease in different selected countries in Europe, we can observe that when we look at the percentage of serotype that could be covered, that the serotypes in each vaccine, PCV20 and PCV21, we can observe that at least in Europe and across the world, it's a little bit different according to the country. We can observe higher. We can observe a higher serotype coverage with the PCV21. For the use of PCV21 in children and adolescents, there is also data showing good immunogenicity and tolerance, and indeed approval is pending in several regions in this population compared to previously data. So it's the reason why this immunobridging allow the approval of first PCV20, and after there is a comparison between PCV20 and 21 that allow the approval of this vaccines. And now we are lucky because we have new vaccines to improve the coverage of these infections and to increase more the efficacy and the effectiveness of pneumococcal vaccines. When we look at the current pneumococcal vaccinations recommendations across Europe, we have many different recommendations, but in childhood programs, most countries will recommend routine infant vaccinations with PCV 10, 13, 15 or 20. So we have plenty different recommendations, but it's important to see that most of the country clearly recommend childhood program. As Federico said, it is very important to prevent pneumococcal disease in this age. We have also different schedules, and it clearly depends on national policy. So it is important to look at what is your policy in your country. The impact of these childhood programs clearly reduce largely the invasive pneumococcal disease, but also the antibiotic resistance and non-invasive pneumococcal disease associated with a large prescription of antibiotics. And it's also induce herd protections for adults. And now it's needs to change probably the vaccines used, because this serotype replacement also observed in childhood infections. For adults, the recommendations depend also on the country, with some countries recommending the vaccination for 60 or 65-year-olds. And usually there is also a recommendation that is independent of the age, but based on the chronic conditions or immunocompromising conditions. And most countries also recommend conjugate vaccines. Most countries now recommend PCV 20 or 21. And in some countries, there is a recommendation for one or other of these PCV vaccines. And now there is even development of other vaccines, and probably in the next years, we have a broader serotype coverage, but it's not the case. What was sure that in Europe, for adults recommendation, most countries now try to propose a schedule with a single dose vaccination and using one of the higher valency conjugates vaccine. Indeed, for now, as I previously mentioned, we don't have for PCV 21, and we just have some release data for PCV 20 about effectiveness data in adults. And it's important to indeed, of course, think about the vaccine serotype coverage, but we need probably to add in the next month and years data about effectiveness regarding the reduction of infections, and it will probably help to better define the use of one of our vaccine. Indeed, in the next years, probably we will have newer pneumococcal vaccines, because there is in development different vaccines with a broader serotype coverage, and it's very important to have a surveillance of pneumococcal serotypes associated with pneumococcal disease, invasive or not invasive, to probably in the future to use in some countries one vaccine with some serotype coverage, and in other vaccines, because probably each vaccine that is very important to prevent pneumococcal disease could be better according to its vaccine coverage associated. When we look at the impact of pneumococcal vaccine, we clearly now also have emphasized the role of pneumococcal vaccination in the impact, in the positive impacts in prevention of cardiovascular disease. And European Society of Cardiology recently released a statement about how it is important to vaccinate people with cardiovascular disease, of course, about pneumococcal vaccines, but also other vaccines. And it's also a way to show how vaccinations can protect people beyond the protection of only infection. So, Federico, can you maybe give us your opinion about the serotype distribution and the availability of different PCVs in different countries?
Yeah, absolutely, Elizabeth. I think that, well, the very first good news, as you already mentioned, is the availability of more and more higher valency pneumococcal conjugate vaccines, no? Both in the infant field, where we already have PCV 15 and PCV 20, and nearly in the near future, we will also have PCV 21, and in the adult field, where we already have PCV 15, PCV 20, and PCV 21 in most of the countries, at least in the European region, which means that we have the latest and I think the broadest coverage vaccines against pneumococcal disease in both age groups. But it's also true that these vaccines are different. They include different serotypes, as you mentioned in your presentation, and then the final decision of using one or other vaccine in each country depends on several factors, and probably one of them is the specific breadth of coverage against the circulating serotypes, and the epidemiology may vary from country to country, and the predominant serotypes, where we saw that if we look at Europe in global, the top of them are the same, but they may vary from country to country, and you can select one or another vaccine depending on the predominance of one or another serotype. But I think the most important thing is that any of these vaccines so far have shown to be safe and immunogenic for those that have been licensed before, like PCV13, PCV7, PCV10, or even PCV21, we already have some real-world data showing that it works in real world. And as you have already stated, the newest vaccines are based on immunobridging studies, but with time we will be able to show how efficacious or not they are against the new serotypes included in these vaccines. But in the meanwhile, I think that it's very important that irrespective of the specific serotype distribution, to stick with the recommendation in each of our countries and to use the PCVs available and recommended and included into our national immunization programs. I think this is key. And I also like to ask you a question in this regard. You have been talking about the newest vaccines, with PCV21 being the last kid in the block, no? But I think it's important to reinforce the idea that this does not mean that the previous PCVs did not deliver or did not work.
For sure. Clearly, since the use of conjugate pneumococcal vaccines, we clearly show a dramatical reduction of pneumococcal disease, but also, of course, of invasive pneumococcal disease. And clearly, it's clearly changed the outcome of these infections worldwide. So we are lucky. We have new vaccines that have been developed because of this serotype escape. But no, we cannot forget that previous vaccines have already have an important impact, and it's now crucial to use these new vaccines and also to increase vaccine coverage, notably in adults, to maintain high level of protections. Okay, I completely agree with you. The development of these new vaccines relies on immunobridging, and that immunoresponse are very important to protect. And now, even we don't have all this data, we need to continue to work to obtain data about effectiveness. But as you perfectly mentioned, with the previous data on PCV, we know that these vaccines are effective to protect against invasive and non-invasive pneumococcal disease.
Yeah, I think that's important, and probably take us to our last part on the discussion today, which we have already seen how important the burden of disease is. You have perfectly outlined that we have very safe, immunogenic, and also effective tools against pneumococcal disease, both invasive and mucosal disease, but very well proved for the let's say older PCVs, and probably will be the same for the newest higher valency pneumococcal conjugate vaccines recently licensed in different countries across Europe. But now the third part links to the idea of, okay, these tools do not work if we don't use them, no? And I think that's an important part I would like to cover and discuss with you for a moment. And I don't think that the actual implementation of pneumococcal vaccines and the use of these vaccines, it's subject to specific factors related to pneumococcal conjugate vaccines, but general to all vaccines. No, thank you, Elizabeth. I think that at this point we can move into the last part of the discussion. We have already seen how important pneumococcal disease is and the huge amount of burden it generates. Also, that we have very safe, immunogenic, and also effective tools, the pneumococcal conjugate vaccines, with some of them already proved to be not only safe and efficacious, but effective in real world. And the newest ones, the PCV21 and PCV20, is still gathering real world information to prove what they have already shown in the immunogenicity and immunobridging studies. However, I think this takes us to the last point, and it's like, no matter we have very good tools, if we don't use them properly. And I think we need to reflect a little bit about that. And I don't think there are specific barriers or challenges with pneumococcal vaccines that are different to those general to vaccination in both the infants and both the adult population. It's true that there is an increasing hesitancy movement across Europe and across the world, and specific barriers can impact like that into vaccination compliance. However, I would say that in the specific side of the pediatric population, usually there is a very high uptake with the pneumococcal conjugate vaccines as other routine infant vaccines across Europe. Nevertheless, it's true that this may vary from country to country, and sometimes the ignorance or the fear, the anti-vaccine climate, the bias that might exist about the too many vaccines being used in children, etc., could impact negatively the actual vaccine uptake. But I think it's worse in the adult field, where usually the vaccine uptake is not of that of pneumococcal, but in general, vaccine uptake in the adult population is even lower, probably because we lack of the specific commitment like the pediatricians had with vaccination in the adult population, whereas different specialists can deal with the adult patient, and sometimes also by a lower level of awareness in the adult population regarding the need of vaccination. I think that this can be solved well with a variety of different measures, including communication solutions, trying to use empathetic dialogue with our families or our patients, try to understand that most of the times the patients do not vaccinate because they are against vaccines, but because they have doubts regarding vaccines that can be effectively solved with honest, transparent, and evidence-based information and education. And I think that reinforced the idea that the most important driving factor for the final use of a pneumococcal conjugate vaccine, but I would say for any vaccine, is the active recommendation by the healthcare professional. And for that, it's key to be first knowledgeable on the vaccine we are talking, and that's why initiatives like today are important to be up to date, in this case, in the pneumococcal conjugate vaccination field, but also to be able to deliver confident messages regarding vaccination to our patients, their families, or the specific adult patient that may need pneumococcal vaccination. So I think that there are good initiatives in this regard, like the Rise Back project, the River EU, which is an Horizon 2020 project dealing with the specific measures, trying to improve vaccination coverage, but in general, information and education and the active recommendation by the healthcare professional are the true determinants into the final decision to get immunized or not immunized, either your children or yourself. And I think that, I don't know what you think about this, Elizabeth, and maybe you can share your personal experience in France in this regard.
Yes, indeed, in France, as many people know, there is a high level of vaccine hesitancy. It was shown, for instance, in Vaccine Confidence Project. But when we look at the pneumococcal vaccine acceptability, I don't think that the low vaccine coverage in older adults about pneumococcal vaccine is due to vaccine hesitancy. As you mentioned, in most of the time, people don't know, are not informed that they are at risk of pneumococcal disease. And if there is a clear, strong recommendation looking at the how it is important to be vaccinated against pneumococcus when we are older or when we have some chronic conditions, most of the people will engage and will be vaccinated. Of course, when people have questions, as you mentioned, it is important to use, for instance, motivational interviewing methods to help and to answer the response, to engage people in what is important for them, and to show how this vaccination could be associated with personal benefits. I also think that it is important, and the example of European Society of Cardiology is very good example. It is very important to place vaccination as a cornerstone of healthy aging, not just as a prevention of infectious disease. And it is the case for pneumococcal vaccination. Um, Increasing pneumococcal vaccination, it's also a way to reduce cardiovascular events in people at risk. And I think that this message, notably in older, could be meaningful and could also help people that are hesitant regarding this vaccination to change their point of view. Of view. And Federico, for pediatrics, what about this relationship with healthcare professional recommendation?
Well, usually in pediatrics, we are in a better situation compared to adult vaccination. And it's true that in general, we have very high uptakes, but we should not rely or fall into self-complacency. We need to keep working. I think it's very important to be up to date with the new vaccines arriving, the new pneumococcal conjugate vaccines, ready to answer the questions that the parents may arise. And importantly, to follow the country recommendations with regards to any vaccine, but also specifically to pneumococcal conjugate vaccines in the pediatric age, to ensure that our children are covered up to date with the vaccines that are included and recommended into our respective countries. So I think there are common needs and common aims with regards to vaccination compliance and vaccination uptake in children and adults. And I like very much your point of including pneumococcal conjugate vaccines as part of a healthy lifestyle and include that as a part of our routine in that regard. I think that with this, we may come to an end. And thank you once more, Elizabeth, for your very insightful comments and contributions. And I think that we could conclude that the most important step is to vaccinate against pneumococcal disease, no matter which vaccine we use, because we know clearly there is a before and after with the arrival of pneumococcal conjugate vaccines. And it's true that we need new pneumococcal vaccines because of serotype replacement, natural change on the predominant serotypes, but the previous PCVs have done their job, and any past X scenario is worse than any present scenario after vaccination. So I think this is an important message we need to emphasize. Also, that we need to prioritize vaccination in the adult population, specifically in adults above 60 to 65 years of age, which is the usual recommendation of PCV in older adults in many countries, but also in individuals with chronic conditions that we know can pose a significant added risk to invasive pneumococcal disease like chronic lung disease, diabetes, or any immune compromising disease. No? And also, I think, as I mentioned just a minute ago in our discussion with Elizabeth, it's very important to ensure we follow the national guidelines that start in infancy with pneumococcal conjugate vaccines being included into the infant immunization program, but they follow on in the adult population, of course, and very importantly also with the specific indications in high-risk groups irrespective of age. So it's important that in the patients we are taking care of, either children, either adults, we get sure that they have their pneumococcal vaccination schedule up to date and adapted to the specific needs and the specific age and risk conditions. Finally, I think that so far, pneumococcal conjugate vaccines have shown their capability to reduce not only invasive pneumococcal disease, namely sepsis and meningitis, but also pneumonia, which particularly in the adult population, is the most frequent and important clinical phenotype. And I think this is essential, knowing the huge burden that pneumococcal disease can actually generate, but also having on our side such powerful tools as pneumococcal conjugate vaccines that keep improving with the recent arrival of PCV20 and now PCV21. And as we speak, we are still working in future generation of higher balancing pneumococcal vaccines. So I think the key takeaway for today is that vaccination is a priority, and we need to ensure that our patients are currently vaccinated with any of the available pneumococcal vaccines, specifically the ones that are being recommended and included into the national immunization programs of our respective countries, and that pneumococcal disease can be beaten through pneumococcal conjugate vaccination. So let's use each opportunity to recommend and vaccinate.
Thank you again, Federico, and I'm very happy to have been with you. And thank you for looking at this presentation, and we hope that it will help you in the future.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co. Incorporated. To access all materials for this activity, visit peerview.com/JNR860.